Welcome back to Symptom Management in the LNX series. In this video, we're talking about managing GI symptoms. Now, this is going to be a big one. There are multiple symptoms that are distressing that originate in the GI tract, and a lot of patients suffer from these. So things that we're going to see, anorexia and cachexia, constipation, diarrhea, nausea, vomiting, and xerostoma. So that is dry mouth, the million-dollar word for dry mouth. Anorexia and cachexia, really anorexia, it's the loss of appetite, and it is typically seen with a decreased intake. Cachexia results from a lack of nutrition, and it's characterized by wasting. There are, of course, cultural considerations and ethical implications in these two. In looking at autonomy, promoting autonomy, you want to allow the patient, you're not going to force feed the patient if they have anorexia. And again, this is anorexia, the loss of appetite that is characterized by decreased oral intake. It is not anorexia, the intentional starving of self to lose weight. So it's not the mental health condition. It is a GI symptom that is commonly seen at the end of life. Ethical implications in this: if a patient doesn't want to eat, we cannot force feed them. However, we feel like we want to give them supplemental nutrition and hydration because it goes against our very nature to watch somebody starve to death. And while at the end of life, it's not that someone is starving to death, they're already dying. The important thing to remember for you and to provide education to family members is that as end of life nears, the appetite is going to decrease. The GI tract is shutting down, and so the patient is not going to want to have that oral intake. How do we show love and hospitality to people? We feed them. And this is true with family members who have a loved one that is dying. When their loved one is no longer eating, they want to provide them with more food. They want to give them water. They want to give them ice chips. It's just what we want to do. We want to feed people to show them we love them. And so where the education comes in is really telling the family members the body is shutting down right now, and feeding your loved one, your mom, your dad, your child, your spouse, is not going to be in their best interest. So here are some other ways that you can take care of them and show them you love them. So we want to keep everyone as nourished and hydrated as we can, especially leading up to those few final days. But at the same time, we are going to promote autonomy and not force feed the individual. We are going to educate the families and let them know that this is what happens at the end of life, and that actually force feeding can cause more harm than good. So causes of anorexia and resulting cachexia are typically disease related, and they're seen most frequently in cancer and heart failure, as well as COPD, HIV, and renal disease. So those are the major chronic conditions causing anorexia that do result in cachexia. Oral or systemic infections may also cause discomfort when eating. And so if someone has a bunch of sores in their mouth, they're not going to want to put food in there and further irritate the sores. Pain associated with eating can be caused by certain disease states, especially pancreatitis. If there's chronic nausea or vomiting, then that can cause anorexia, obviously. Things like delayed gastric emptying, diarrhea, malabsorption, bowel obstruction, raised intracranial pressure. These things can all cause anorexia. So again, important to identify the underlying cause so that appropriate treatment can be implemented. Assessment, physical findings: you're going to see that the patient isn't eating, that they're losing weight, that they are wasting away. You will see decreased albumin in the lab tests. You're going to see skin breakdown. And you may see an impact on ADLs, activities of daily living. You may see an impact on pain, and definitely on quality of life. Different ways to address anorexia and cachexia is, again, identify the underlying etiology. If it's sores in the mouth, there can be some local anesthetics that can be applied to the sores, and the sores can be treated. If it's infection, antibiotics treat the infection. If it's nausea, antiemetics. So identify what it is that is causing this, and then bring in your dietitian. Find some sort of dietary plan that has protein-rich supplements. Maybe it's protein shakes, maybe it's smoothies with proteins in it, what have you, but really work with that dietitian. There can, of course, be parenteral or enteral nutrition. So that's artificial nutrition either through the IV or directly implemented into the GI system. This one is important to remember the burden-benefit ratio again. Ask yourself, would artificial nutrition be prolonging life and promoting suffering, or would it be promoting quality of life? Odor control can be a huge thing with anorexia, especially if someone has a condition that causes sores that may become infected. I have seen some pretty nasty tumors that have emerged to the surface, and it can be very, very visually disturbing, and it can also be cause various odors that can cause anorexia. So addressing those as well. Constipation. I'm sure all of you are familiar with constipation and the obsession that older adults have with their bowels. But in end of life, it is very important to prevent constipation. So different causes. Again, you're going to identify the underlying etiology. Obstruction, hypercalcemia, is it neurologic? Is it due to inactivity? Can it be, is it from long-term opioid treatments? What's causing the constipation? And then the assessment to identify the underlying etiology as well. So bowel history, abdominal, rectal, and then medication review. Are there multiple medications such as opioids the patient is taking that causes constipation? Treatment of constipation, typically there's going to be pharmaceutical intervention. Remember to think, what are, in the underlying etiology, has there been a decreased oral intake? Is the patient dehydrated? What is the patient eating? Are there dietary alterations that can occur? And what non-pharmacological interventions can occur concurrently with the pharmaceutical interventions? So really, treatments for constipation pharmaceutically are broken down into kind of a mush and push sort of state. So the mush is talking about the peristalsis, and the push is the stimulant. So mush, peristalsis, everything needs to be soft enough to be moved through the GI tract, and then the push is that stimulant. So there are different levels of, if you would like, call them dynamite. Milk of magnesia is going to be your most gentle dynamite. Bisacodyl is going to be the big dynamite. And the magnesium is the be in the bathroom all day dynamite. However, these, while on the healthy GI tract, those are the various levels of dynamite, if you will, they may not work for the patient, and it may require multiple levels. It may require oral medications, maybe suppositories, maybe enemas. So depending on the degree of constipation will depend on the treatment appropriate. And now for the opposite problem of constipation, we have diarrhea at the other end of the spectrum, and that is that frequent passage of loose, non-formed stool. Now, diarrhea has multiple adverse effects. It can cause fatigue to both the patient and the caregiver. It can really increase caregiver burden, and it can cause skin breakdown on the patient. Causes of diarrhea, again, it may be disease related, it may be malabsorption, concurrent diseases. Remember, rarely does a patient have one thing going on. Some of the things that can cause it may be bacterial or multibacterial or parasitic infections can cause the diarrhea. It could be a partial bowel obstruction or fecal impaction. Sometimes when there is fecal impaction and multiple stool softeners are given, all that does is soften the edge of the impaction. So you're going to have those loose stools going away from the edges of that fecal mass, but the mass stays in place because it is so hard and formed that those the mush and push, those uh, medications for constipation are not going to do anything to move it through the body. Malabsorption may occur from the presence of other things such as pancreatic tumor, or it could be following GI surgery, things such as gastrectomy for GI cancers. Concurrent diseases that could cause it would be GI malignancies, hyperthyroidism, irritable bowel syndrome is a big one. So if someone has IBS throughout their life and then suddenly they develop a terminal diagnosis, that IBS isn't going away. You still need to treat it and manage it. So again, treatment, it's going to be determined by the underlying etiology. So is it chemotherapy? Is it infection? Is it medication? Is it part of the disease pathology? And then consider the psychological consequences of diarrhea. So diarrhea, again, can increase that social isolation if the patient needs to continuously be going to the bathroom, or if the patient is bedridden and incontinent. Think about them not wanting people to come visit them, or perhaps people are uncomfortable to come visit them because they, unlike us nurses, have the benefit of being able to avoid poop, whereas we do not, and so that can increase this social isolation. Again, your assessment is going to be with all the in line with all the other symptoms. So you're going to do that history, medication review, your physical assessment. You're going to look for infectious processes as well. Treatments, again, underlying cause. Perhaps it's dietary modification, so get your dietitian on board again, talk with them. Perhaps the patient, consider hydration, because thinking about all of that loose stool, that's a lot of fluid leaving the body, that's a lot of electrolytes leaving the body. So let's keep a close eye on fluid status and on electrolyte balance, because you don't want additional complications being caused by that diarrhea. As far as pharmacological agents are concerned, Imodium, just a simple over-the-counter, is going to be one of the first line treatments for treating diarrhea, especially chemo-induced diarrhea. Other medications that are helpful are things like opioids. Think about that. They slow peristalsis, so that is going to help the stool become more formed. Different absorbents like I always say this one wrong, psyllium, things like anticholinergics, and then like pancreatic enzymes or something like that if it's a malabsorption issue. Moving on to nausea and vomiting. Unfortunately, nausea and vomiting are two of the most dreaded side effects. They are also two of the most common symptoms with the advanced disease process. And they can occur in up to 70% of patients with advanced cancer, and about 30% of patients otherwise in end of life. So again, these symptoms haven't been well researched, and so it's difficult to know really, are we giving the patients evidence-based practice? Are we providing evidence-based care to them? When you're looking at it, same with all the other ones, we're going to look at the underlying pathology, we're going to look at the symptom etiology, and then we're going to treat the underlying cause. So some of the causes, it can be physical or psychological. It can also be disease related. So anything like for physiological, gastrointestinal causes. So it's going to be a lot of different things. It could be to gastric stasis, constipation, obstruction, pancreatitis, ascites, liver failure, radiation, chemotherapy, visceral disturbance. I mean, there's so many different things that cause nausea and vomiting, which can make it very difficult to treat. Metabolic imbalances can occur as well, so you've got to think about your fluids and electrolytes if you have a patient with intractable vomiting. So addressing that fluid balance, addressing that electrolyte balance. So some of there can be emotional factors, obviously. And the psychological implications, these can really be a result of, vomiting is stimulation of the emetic sensor in the brain, and that can be emotional as well as physical. Disease related, any type of disease causing nausea and vomiting. This could be a brain tumor, it could be a liver tumor, it could be renal failure. Patients on dialysis tend to have a lot of trouble with nausea and vomiting. It could also be treatment related. Things like radiation, chemotherapy, opioid use, NSAIDs, antibiotics, antiretroviral therapy. Yeah, you know the drill. Every single medication causes nausea, vomiting, diarrhea, and possibly constipation. So, what is the patient being treated with, and is any of that treatment causing the nausea and vomiting? I'm sure you've noticed a pattern. Assessment, physical history or physical exam history, lab values, you're monitoring for dehydration. As far as treating nausea and vomiting, there are various pharmaceutical interventions that can be helpful. So anticholinergics can be very helpful in treating motion sickness as well as intractable vomiting or vomiting related to a small bowel obstruction. Antihistamines are commonly used with intestinal obstructions as well. They can be helpful with increased intracranial pressure, peritoneal irritation, different vestibular causes. So if there's an inner ear thing, then those antihistamines can be very helpful in treating that nausea and vomiting. Steroids can be given either alone or with other medications. They're really helpful with cytotoxic induced enzymes, so a lot of, or emesis, sorry, a lot of cancer related or chemo related nausea and vomiting. So things like dexamethasone are really helpful, especially if the cause of nausea and vomiting is unclear. There's different prokinetic enzymes such as metoclopramide that can treat gastric stasis. Benzodiazepines are helpful. You've got that lorazepam. It's especially helpful in nausea that is caused by anxiety. Different things like the 5-HT3 receptor agonists are really helpful in postoperative nausea and vomiting, as well as chemo-related nausea and vomiting. So things like ondansetron are going to be helpful in that. Opioids, altering the dose of opioids can be helpful. Sometimes the dose is too high, or sometimes the opioid needs to be changed to a different one. Maybe oxycodone causes vomiting, but Vicodin doesn't. So think about changing opioids if the patient needs opioid pain management. As with everything, we want to think about non-pharmacological interventions in addition to the pharmacological interventions. So things for nausea and vomiting, distraction can be really helpful, especially if it's a psychological cause of nausea. Maybe someone likes to read a book or watch a movie or listen to music or have a family member there or just have a conversation. Maybe a chaplain needs to be involved or a therapist, something like that. Teaching the patient different relaxation techniques, helping them recognize when they become anxious, which causes that nausea, so that they can have that pause and start practicing the relaxation exercises and then decrease the nausea. Dietary modifications can be helpful as well. Maybe it's a food that is causing nausea. If the patient is in hospital and dietary options are limited, again, bring that dietitian in, have that consult, and talk to that patient. What is it that the kitchen is bringing you that's causing your nausea? Things like controlling odors is a huge thing to be helpful with nausea. Other things, keeping the room cool, dimming the lights, maybe a cool cloth, simple things like soda crackers or 7-Up, different things like that can be helpful. Other things, some of those invasive therapies, maybe it's constipation that's causing it, so you need an aggressive bowel regimen. Maybe it's pancreatitis or ascites. Maybe it's radiation. So you need steroids for a brain metastasis to cause that decreased inflammation, which will alleviate the pressure on that emesis center within the brain. So there are different things, and again, you will be able to identify these by identifying the underlying etiology. And last but not least, we will talk about dry mouth and the dreaded hiccups. I don't know about you, but hiccups are one of the most inconvenient things that can happen in my entire life. So I cannot imagine intractable hiccups at the end of life. I've actually seen this in patients, and I don't know who's bothered more, them or me, because I hate hiccups so much. But these hiccups can happen at the end of life, and so it's important to be able to identify the underlying cause and, again, to treat it. So sometimes GERD causes hiccups or gastric distension because it's causing pressure on the nerves. So things like corticosteroids can be very helpful, and benzodiazepines can be as well. For dry mouth, that can occur for a number of reasons. Maybe the patient is NPO. I did have a patient whose entire jaw had been removed from cancer, and obviously he was NPO, couldn't have anything by mouth, and while that lower jaw wasn't there, he still did have dry mouth, and so things like little swabs were very helpful. I mean, he couldn't swallow, so you couldn't give him ice chips, but just those little glycerin swabs, those little green sponges dipped in water, can be very helpful in alleviating that dry mouth. Other things that can be helpful, the ice chips, if the patient's not NPO and they can tolerate that. If they're on thickened liquids, do not give them ice chips, because ice chips melt into thin liquids and you could cause aspiration, and that leads to a whole nother host of issues. So with everything, identify the underlying etiology, do a thorough assessment, implement your treatment based on your assessment findings and interactions and collaboration with the interdisciplinary team, and then reassess the patient to determine whether or not the treatment and interventions have been effective.